Hello and welcome back. In chapter 8, we're discussing trauma and stressor related disorders. These disorders in this section of DSM-5 are characterized by the symptoms that occur after a traumatic or stressful event happens in someone's life. So they're usually a combination of anxiety or anger as a part of the symptom picture. And two disorders are included in this chapter that share a common etiology of social neglect, understood as the absence of adequate caregiving during childhood, and they are reactive attachment disorder and disinhibited social engagement disorder. So let's talk about reactive attachment disorders. In the individual's first 2 years of life, they need to develop the ability to have secure attachments. The brain needs to regulate this ability. If you have neglect or abandonment in those first 2 years of life, your brain would struggle to have secure attachments, which can lead to a reactive attachment disorder, which is characterized by a rare disorder found in children who lack attachment despite their developmental capacity to form them. The core features of RAD disorder include failure to seek or respond to comforting when distressed, with social and emotional disturbances, seen with at least two of the following: minimal emotional regulation, reduced positive affect, an episode of unexplained fearfulness and anxiety. Children with a history of living in settings with limited attachment opportunities are at higher risk. Symptoms begin before the age 5 and usually can be seen while still an infant and must have a developmental age of at least 9 months. Disinhibited social engagement disorder, a disorder of children's social relatedness. The central feature is that the child has experienced some serious neglect or pathogenic care very early in life. Behavior includes an inappropriate approach to unfamiliar adults and lack of awareness of strangers and willingness to wander off with strangers. The child has experienced extremes of insufficient care that limits attachment opportunities and can persist into middle childhood and adolescence, but has not been described in adults. PTSD, or post-traumatic stress disorder. Close exposure to the trauma seems to be the main aspect of developing PTSD. Major reference points include the reaction to catastrophic events such as witnessing a homicide or suicide, traffic accidents, combat, natural disasters, sexual assault, victimization, survivals of Holocaust, life events such as domestic violence, or a diagnosis of HIV. The PTSD symptom picture. The central feature of PTSD is exposure to actual or threatened death, serious injury, or sexual violence. Exposure does not include events seen only in electronic media, television, movies, or pictures. Now remember, with PTSD, your brain becomes hyper focused on that event because it becomes a threat to your safety and happiness, which are the prime directives of the brain. The hypersensitivity and the hyper focus of these can cause a lot of cognitive distortions, right? So symptoms must last for at least more than 1 month and significantly affect important interpersonal areas of the person's life, such as family interaction or employment. PTSD is not reflective of another medical condition or effects of a substance such as medication or alcohol. So the symptom picture continued. The practitioner considers 4 symptom clusters characterized by the following: re-experiencing the event. They must have one or more of the following intrusive symptoms, just one, with the traumatic event: spontaneous memories of the traumatic event, recurring dreams related to it, flashbacks, or other intense or prolonged psychological distress, and marked physiological reactions. Voidance. You must have one or both of the following two: distressing memories, thoughts, or feelings of external reminders of the event. Efforts to avoid external reminders that provoke distressing memories, thoughts, or feelings associated to the event. Negative thoughts and mood or feelings. You have to have two or more of the following: inability to remember key aspects of the event. Negative thoughts about oneself, others, or the world, such as I am bad or no one can be trusted. Feelings that may vary from persistent or distorted sense of blame or self of others. A persistent negative emotional state such as fear, horror, anger, guilt, or shame. A markedly diminished interest in activities to estrangement from others. feeling of detachment or estrangement from others, and finally, an inability to experience positive emotions such as happiness or love or feelings. So again, they must have two or more of that one. Finally, we have heightened arousal. They must have two or more of these: aggressive, aggressive or angry outburst, recklessness or self-destructive behavior, hypervigilance, exaggerated startle response, problems concentrating, or sleep disturbance. Specifiers for PTSD, right? They are exposed to traumatic events may not inhibit PTSD features until years after. So we need to specify with delayed expression. The person might also experience dissociative symptoms. So we must specify dissociative symptoms. Let's talk about acute stress disorder. This looks very similar to PTSD, but this is going to form a lot faster. And the timeline is going to be different, right? So it looks like PTSD, but there's going to be some symptoms within the first month immediately following the trauma. It includes 9 of the 14 symptoms of the following categories: intrusion, as seen by recurrent involuntary and intrusive dream, distressing memories of the event. The content of recurrent distressing dreams related to the event. Dissociative reactions such as flashbacks. Intense prolonged reactions. We got to have negative mood, persistent ability to experience positive emotions such as happiness, satisfaction, and love and feelings. Disassociation, understood as an altered sense of reality of one's surrounding or oneself, much like being in a daze or a time has been slowed or seeing oneself from another's perspective. Been unable to remember important features of the traumatic event. Avoidance, considered to be efforts to avoid distressing memories, thoughts, or feelings about the event. Trying to avoid external reminders such as avoiding people, places, or conversations or activities to provoke distressing memories. And thoughts or feelings about the traumatic events. Arousal, regarded as sleep disturbances, irritability or anger outburst. Hypervigilance, difficulty concentrating, and exaggerated startled response. Let's talk about adjustment disorders. Adjustment disorders generally occur as a reaction to life-threatening events and tend to last longer than assessing for adjustment disorders includes. The stress is out of proportion to the severity of the intensity of the stressor. Once the stressor or its consequences have ended, so they have ended, symptoms do not persist for more than a 6-month additional period. So consider 6 of the following specifiers: with depressed mood, with anxiety, with mixed anxiety and depressed mood, with disturbance of conduct, with mixed disturbance of emotion and conduct, and unspecified. Finally, let's talk about the other specified or unspecified trauma and stress-related disorders. Specified trauma and stress-related disorder applies when the person's symptom picture does not meet full criteria for the disorder for any of the disorders in this section. So that's going to be other specified. Again, when a client they have symptoms of trauma, but they don't meet the full criteria for it, but they have significant dysfunction, we're still going to diagnose other specified trauma or stress-related disorders. So unspecified trauma and stress-related disorder applies to those who present with symptom characteristics of trauma and stress-related disorder and used in situations when the practitioner elects not to specify the reason that they don't meet the diagnostic criteria.